that all common question every patient wants to know, is my chemotherapy working? So you go into your oncology office and you see the doctor and you run the laboratory tests. What's going on with my tumor markers? And then you can't wait for the imaging to see what's actually happening to the tumor. And it's kind of like you're waiting and then what's the results? It's a little better or it's not. And then what do we need to do? At Envita, we've seen this for years because our patients come after they've failed usually conventional care. They're later stage cancers that are refractory to treatment typically. And we can tell you that there's so much more to the treatment of cancer. The real question to ask is, how was my treatment plan built? why were these therapies selected for my individual cancer? That's the real question. And you'll find that the answer is interesting. The methodology that's currently used is very outdated. It's based on clinical trials. Now, clinical trials are where you take people with all the same types of cancers, like squamous cell carcinoma, right, of whatever tissue, and they all given the same thing, and then they look at the outcome. The problem with that is that old methodology may work for a chronic, maybe infection, but it doesn't work in cancer, and here's why. Cancer is a moving disease. Those cancer cells are constantly mutating, and those biomarkers, molecular targets are constantly changing. So in the conventional model, where they basically use an algorithmic cookbook, so to speak, to say this is first-line therapy, if you fail, this is second-line therapy, all the way to clinical trials. In our setting, it's totally different. You, the patient, are N of 1, which means we build the entire clinical treatment on you like a clinical trial where we're taking from your genomic data, your immune system data, causative factors of the cancer, other factors that are helping the cancer grow. And then with that information, we're building the treatment plan based on your genomics. That's why you'll hear us say we usually outperform. Why? Because the patients who are coming to us have already failed a lot of the conventional care from big time cancer centers and clinical trials. And then we help them respond because we're using that level of detail. It's not a 10-minute appointment or 30-minute appointment with a physician. It's a detailed treatment that's built off of all of these factors. And then once you do that, then we can say, this is why we selected this and that. And to make it even a little bit more complicated, when we treat, we look at different mechanisms of action to kill that cancer cell. So in the conventional model, I'll use chemotherapy here. If you're using 2-3 drugs, boy, the side effect profiles can be in the thousands, tons of side effect potentials that are there. What we do is because we have the targeted genetic testing and we know better what to give, we can use a lot more agents, but at microdoses called metronomic dosing. So we get a better mechanism of action to go after the tumor, and we reduce the side effects significantly. Now that's just one area, and we do that genomic work in our immunology area, and we do that also in the causative factors of the cancer. So I hope this helps to answer the question more in depth. Is my chemotherapy working? And the better question is, what was the treatment plan that was used, and how am I going to monitor my success? And once you have these genetic factors dialed in and immunotherapy dialed in, you typically will see patients improve in their numbers, improve in their imaging, but the key is making that happen long-term to improve quality of life and to improve outcomes for our patients. So thank you for joining me. I hope this helped answer that question that we hear all the time with patients.